So good morning, everybody. Like Ma'am said, my name is Frank Davis. I'm one of the Vascular Chief Fellows here at Michigan. Today, I'm going to be talking about aortic endoleaks, both what they are as well as why we should care about them in the BMC2 in terms of long-term surveillance. So to begin, I have no financial disclosures. I'm also going to kind of give a brief overview of my presentation here today, just so we can all be on the same page. First and foremost, I'll talk about kind of early studies that came out in the probably beginning of the 2000s that demonstrated the importance of endovascular aortic aneurysm repair, and that showed how it had an early survival benefit in comparison to open abdominal aortic aneurysm repair. I'll then move on to talk about kind of the long-term durability of endovascular aortic aneurysm repair, as well as why it's important for us to continually surveil these patients during their postoperative period. Then I'll move to talk about endoleaks, both what they are and the different types that you might encounter as you're kind of reviewing or surveilling these patients. I'll talk about the SVS guidelines for endovascular aortic aneurysm surveillance that were published in 2018 and kind of the guidelines that are currently available. And last but not least, I'll talk about the impact of endoleaks in terms of patient postoperative morbidity and mortality. And this really, I think, hits home in terms of the importance of long-term surveillance for these patients, not just within the 30-day window, but also years after their endovascular repair. And then at the end, I'll leave some time for questions. So if anybody has any questions during this presentation, please feel free to just post them in the chat and then we can touch base and talk about them at the end of the talk. So thank you. So first and foremost, as we all know, over the past kind of decade, there's been a significant expansion of endovascular surgery. Much of this expansion was started in the early 2000s with some pivotal studies, that one of which is shown here, that demonstrated that endovascular aortic aneurysm repair has a significant and early survival benefit in comparison to open abdominal aortic aneurysm repair. Shown here is the DREAM trial, which was published in 2005 in the New England Journal of Medicine. And as you can see here, based upon the red line, that at 2 years or 24 months, the endovascular aortic aneurysm repair had a significant decrease in postoperative patient morbidity and mortality in comparison to open abdominal aortic aneurysm repair. However, as research continued over the years, multiple large international studies have demonstrated that this early survival benefit of endovascular aortic aneurysm repair actually wore off. Somewhere between 3 to 5 years, as demonstrated by the EVAR-1 and OVER trial, the intersections between endovascular repair and open repair actually coincided. And as such, there was no long-term difference in total mortality or aneurysm-related mortality for open and endovascular aortic aneurysm repair. Investigations into why this initial upfront benefit of endovascular repair did not persist long-term demonstrate that patients who underwent endovascular aortic aneurysm repair still had a long-term risk of aneurysm-related mortality over their course of the lifetime. Indeed, as shown in this study, which tracked 1,700 patients over a 15-year time period, they found that 3.6% of EVAR patients actually suffered an aneurysm-related mortality or delayed rupture, even though they were supposedly repaired by an endovascular aortic aneurysm device. Further, this study went on to show that 36% of patients who receive an endovascular aortic aneurysm repair actually continue to have aneurysm sac growth of greater than 5 millimeters over their course of the remainder of their lifetime. The rationale for this persistent risk following endovascular aortic aneurysm repair has often centered on a discussion of endoleaks. So first and foremost, what are endoleaks? Well, endoleaks are defined as a persistent blood flow in the aneurysm sac after the endovascular aortic aneurysm stent graft is put in position. In total, there's 5 different types of endoleaks. Type 1, which is shown here, involves an incomplete seal at either the proximal or distal aspect of the endovascular device. So shown here, you can see that blood is then creeping around the stent graft and flowing into the aortic aneurysm sac, either up proximally here, which is a type 1A endoleak, or distally here, which is a type 1B endoleak. This type of endoleak is the most serious form of endoleak because, as you can imagine, this is full pressure arterial blood that gets into the aortic aneurysm sac, and as such, it has an increased risk for aortic rupture. The second type of endoleak is a type 2 endoleak, shown here, and this involves the filling of the aneurysm sac through collateral blood vessels, such as lumbar arteries or the inferior mesenteric artery. Third type of endoleak is a type 3 endoleak, and it involves persistent filling of the aneurysm sac based upon an incomplete seal or junction of the components of the aneurysm device. Shown here, you can see that the components don't overlap properly, and as such, you get leakage of blood around those components. A type 4 endoleak is involved in terms of graft porosity. And although this is a documented type of endoleak, this endoleak was initially common in early devices of the endovascular aortic aneurysm repair era. And as devices have improved in technology, this endoleak is much less common in the current era. Last but not least is a type 5 endoleak. This endoleak, also called endotension. So if you ever hear that terminology, that's what they're referring to. But this involves a persistent growth of an aortic aneurysm sac when no significant leak can be identified on CT scan imaging. This is often secondary to the blood flow that's trickling into the aneurysm sac being so low in velocity that the CT scan imaging cannot define it based upon its sensitivity. So based upon these type of endoleaks, by far the most common and most important endoleak that you'll see probably when you kind of review patients' postoperative surveillance is a type 2 endoleak. And indeed, a type 2 endoleak accounts for approximately 75% of the endoleaks that are at all reported. Indeed, at the time of initial repair, approximately 50% of surgeries will document a type 2 endoleak. However, it's also important to recognize that endoleaks don't just develop at the time of initial surgery. In contrast, countless studies have demonstrated that endoleaks can develop at any time throughout the postoperative period. And as you can see here in this study, almost 1/4 or 21 or 22% of endoleaks were documented at 2 years after an endovascular aortic aneurysm repair. Thereby, it's important, as I've said several times, is that we need to continually surveil these patients because endoleaks, although not present initially, can develop throughout a patient's lifetime. Given the importance of endoleaks on the long-term durability of endovascular repair and the fact that endoleaks can develop throughout a patient's lifetime, the recent SVS, or Society of Vascular Surgery guidelines for the management of patients with abdominal aortic aneurysm repair strongly recommend that patients who receive an endovascular aortic aneurysm repair continue to have constant monitoring. Indeed, they recommend that patients who have an endovascular aortic aneurysm repair receive post-op surveillance at 1 month, 12 months, and then annually for the remainder of the patient's lifetime. The hopes of this postoperative surveillance is that if an endoleak does develop, we as the vascular surgery care team can recognize that endoleak early and thereby potentially intervene on it before it causes significant harm. So why does the Society of Vascular Surgery so strongly recommend the importance of annual surveillance and follow-up to investigate endoleaks? And I guess to put it quite simply, I mean, these endoleaks can have profound implications on patients' postoperative care and their long-term survivability. Shown here is a recent study that was published that followed 550 patients after endovascular aortic aneurysm repair, and it documented the progression of these patients' aneurysms separated into patients who had a type 2 endoleak, shown here in the red dotted line, in comparison to who do not have a type 2 endoleak, shown here in the blue dotted line. And what they found is that patients who had a documentation of a type 2 endoleak, they were 5 times increased risk for developing aortic aneurysm sac progression or enlargement. In addition, these patients were 4 times increased risk of needing an intervention. So 1, if not more, further surgeries in order to repair their aneurysm. In addition, type 2 endoleaks are important as these type 2 endoleaks can place patients at increased risk of developing more severe endoleaks, such as type 1A endoleaks. As I previously mentioned, type 1A endoleaks are the most severe form of endoleak because it allows the full systolic blood pressure to be felt on the aortic aneurysmal wall and thereby has the highest risk of patients rupturing their aortic aneurysm. This study, which was published in 2020, demonstrates that of all patients who develop a type 2 endoleak, 21% of them will go on to develop a type 1A endoleak and thereby increase their risk of potential rupture or mortality. Lastly, endoleaks have implications not only on aneurysm sac growth and reinterventions, but also have implications on long-term mortality. Multiple studies have demonstrated that patients who undergo endovascular aortic aneurysm repair can continue to have 5 millimeter or greater of aneurysm sac growth and thereby increase risk of mortality. This sac expansion is often driven by the presence of endoleaks, and as such, an endoleak can have a direct impact on patient postoperative mortality. It is thereby vital that we as the vascular surgery care team continue to surveil these patients long-term and reach out to them if they miss their postoperative CT scans, because these postoperative CT scans are crucial to document the presence or absence of an endoleak and thereby determine if patients need any further reintervention. So in summary, kind of during this presentation, I talked a lot about endoleaks. I first off talked about the endovascular aortic aneurysm trials that initially laid the foundation for EVAR, both detailing the early postoperative benefit, but also kind of how long-term these endovascular aortic aneurysm devices continue to have or can have postoperative complications that predispose them to long-term issues with durability. We talked about the 5 different types of endoleaks, and the most common one you guys will come across is probably a type 2 endoleak that has flow of the blood via collateral pathways. We talked about the SVS guidelines and the importance of 1 year and annual post-op CT follow-up. And then last but not least, kind of really hit home the importance of endoleaks and kind of how they can have long-term implications and ramifications for patients on sac expansion, reintervention, or even mortality. So that's all I had for today. I'm happy to address any questions that people have about endoleaks or the postoperative surveillance or annual surveillance at this time.
Thank you, Dr. Davis. Does anyone have any questions for Dr. Davis? Dawn Peter says that was great. I have a couple questions.
Yeah.
So I saw on your slide, the data shows that the percentage of endoleaks that occur within 30 days and then greater than 30 days and 2 years and then greater than 2 years.
Yeah.
Is there data out there that shows what percentage of endoleaks occur specifically at 12 months?
At 12 months?
Yeah.
There's not, off the top of my head, there's not data that specifically shows that they occur, what the percentage at 12 months, but with 50% of endoleaks, or excuse me, with 50% of the cases typically reporting a type 2 endoleak within 30 days, I'd
Yes.
say it's probably somewhere between 40 to 50% that continue to have a persistent endoleak at 12 months.
Wow. Okay. And of the endoleaks that needed a subsequent intervention, what percentage of those interventions ended up being an open AAA repair?
Good question. So that's a minority. So somewhere around 10 to 15% needed open AAA repair and open explant.
Uh-oh, it looks like Dr. Davis.
With the topic of reinterventions is patients who have an endoleak will require one, will require one, if not more, endoleak reinterventions.
Okay. You froze there for a couple minutes, for a minute.
Sorry, can you hear me now?
Yeah, the last thing I heard was 10 to 15% end up in open AAA repair. And I didn't hear what you said after that.
Oh yeah, so and then, but I will comment then, if they don't get an open AAA repair, they will get an endovascular reintervention, and that can be one, if not more. So it's common that we see patients who've had 3, 4 endovascular reinterventions for a persistent endoleak.
So for an endovascular reintervention, would you say explanting the main body and putting in a new main body, would that be the most common form of intervention?
So typically for an endovascular repair, for a reintervention, the most common is to probably place an additional device within the first device. You don't actually explant that device.
Okay.
The second most common way to intervene from a reintervention standpoint is with the type 2 endoleaks, those collateral blood vessels I talked about. Yeah. You can block those off by placing a number of different embolization plugs or coils in those collateral vessels. So there's a number of different technical ways you can get in those collateral vessels, but ultimately to stop those blood vessels from flowing into the aneurysm sac is kind of what that reintervention would detail.
Oh, that makes sense. Thank you, Dr. Davis.
Yeah.
I'm just going to look in the chat to see if there's anything else. Christy Todd is asking, is there a difference when you intervene with a AAA repair between men and women? If there is a family history of AAA rupture, what is a screening for family? Good question.
So there's been a great question, Christy. So there's, to my knowledge, there's no studies that have talked about the difference between men and women in terms of the risk of endoleaks or the risk of reintervention. There is a difference in terms of just native aortic aneurysms. In terms of women, typically before they're repaired, will have a risk of rupturing at a lower diameter than men. but not after they're repaired. There's no good data for that. So, but it's a good question. And then your second question, if there is a family history of AA rupture, what is the screening for family? So great, yeah. So for screening for family, if they have a family history, not just of aortic rupture, but any family history of aortic aneurysm, so in the father, the mother, or any distant brothers or sisters, that individual who's genetically related to the other individual with the aneurysm should get a one-time abdominal ultrasound screening study. So it's important. I counsel all my patients who come in with aortic aneurysms, and typically, just because of the nature of the disease, it's men in their 60s to 70s. I then talk to them specifically about if they have children, that those children need to be told that that person has an aneurysm, as well as those children need to go and get screened. And I also counsel them on their siblings too, that they need to tell their siblings, and those siblings need to get screened.
Christy has another question. At what age do you get the ultrasound?
Yep. So typically I say if they are a non-smoker at the age of 65, if they are a smoker, then I say they should get the ultrasound. The relative should get the ultrasound once they know that their other relative has an aneurysm, because smoking is a significant risk factor. So if we can catch it early, we can potentially do counseling and other things like we're going to talk about today, smoking cessation, to potentially help with prevention of the aneurysm growth.
All right, awesome. Are there any other questions for Dr. Davis? Angela is asking, is there an aneurysm size alone that indicates repair?
Yeah. So when patients have endoleaks, just the presence of an endoleak does not indicate reintervention. If the patients have a growth of greater than 5 millimeters in the aneurysm after the endovascular aortic aneurysm repair and have a presence of an endoleak in that indication, then that will qualify them for a reintervention. And the reason for that is often based upon the data I presented today, that once patients who have had an endovascular aortic aneurysm repair, but have an endoleak and the aneurysm continues to grow greater than 5 millimeters, that puts those patients at an increased risk of aneurysm-related rupture or mortality. So that is kind of the cutoff for when we want to intervene on these patients.
Thank you. I'm looking to see if are any more questions. Cindy is asking, is CTA the gold standard for follow-up at 30-day and 1 year? If there is a contraindication for some reason for CTA, is ultrasound or even abdominal X-ray just as good?
Yeah, great question, Cindy. So typically it is recommended that you obtain a CTA at both 30 days and 1 year, and then annually moving forward. New data has come out that if the patient cannot get a CTA, typically because of chronic kidney disease or an iodinated contrast allergy, although you can pre-treat them for that, that patients can also have ultrasounds with contrast or with bubble contrast to determine if there is any endoleak. Our typical practice here at Michigan is the patients get a CTA at 30 days and 1 year. And if both those the 30-day CT and the 1 year CT show no endoleak, then we go to screening ultrasound moving forward. That ultrasound allow you to analyze the aneurysm sac. If it grows by greater than 5 millimeters, or you see any growth on the ultrasound, then we resort back to getting a CTA. Kimberly, yeah, no, this is a great question, Kimberly. Seems like a lot of contrast and radiation over a patient's lifetime. Kimberly asks, it seems like a lot of contrast over lifetime. Is this a potential issue? And there's been no documented data about the long-term ramifications of annual CT scans for patients or via contrast or radiation, but it is something I counsel my patients on. So if the patient is a 50-year-old male who has an aneurysm and we can do it open or endovascular, I actually counsel them and says, listen, if we can do it open, we get you through this will be one and done, and you don't need any annual surveillance moving forward. That decreases your contrast and radiation throughout your lifetime. So it's something I typically counsel my patients on.